If you've ever felt a little unsure or even overwhelmed approaching syncope as a chief complaint, you're not alone. It's not that you don't know enough diagnoses, it's that syncope can feel difficult to organize in your head. The good news is, there's actually a very simple way to approach it. Syncope is not primarily a diagnosis problem, it's a risk stratification problem. And if you use this framework, safety first, then patterns, followed by key diagnostic forks, you can walk through almost any syncope case in a clear, methodical way, whether it's on an exam or in clinic. For example, if a patient passes out after standing with a prodrome and recovers quickly, you should already be thinking vasovagal. Before we even think about diagnoses, we need to answer one question first. Was this actually syncope? Did they truly lose consciousness? Then we'd want to ask about any red flags. We'd want to check for exertional syncope, if there's no prodrome, chest pain or palpitations, is there a family history of sudden cardiac death, any abnormal vitals. Because if any of these are present, that's not a pattern recognition problem anymore. That's an ED referral and cardiac workup patient. Everything else comes after that. So we'll apply this framework to an example 22-year-old non-binary AFib patient who has a chief complaint of syncope. At this stage, you want to keep your differential list pretty broad, but organized. So you can think of it in categories like life-threatening would be arrhythmia, structural disease, PE, anemia. There could be a reflex, which is the most common, and that would be vasovagal. It could be an orthostatic cause due to volume, meds, or autonomic. It could be neurologic causes like seizure or stroke. And then we can have an other category for hypoglycemia or psychogenic. Basically, you're not picking a diagnosis yet. You're just preparing to narrow it down from here. So this is the most important concept in syncope. Syncope is not a diagnosis problem. It's a pattern recognition problem. So for an emergency pattern, you'd see things that are exertional, there's no prodrome, and there's abnormal vitals. If you had more of a benign pattern, there'd be prodrome, triggers are known, and there's rapid recovery. Everything you do next is just figuring out which risk tier your patient fits into. Now we can ask a few focused questions to help us narrow down our differential list. So first we want to ask if there was true loss of consciousness. If there was, then syncope is likely. If not, then this isn't syncope. Next, we'd want to determine if there is true syncope, was there a prodrome? So did they feel lightheaded, nauseous, or sweating? Then we'd be thinking vasovagal cause. If not, this puts them into a higher risk category. Next, we'd want to ask, what were they doing when this happened? Were they standing? That's more likely orthostatic or vasovagal. If there were exertion or they were lying supine, it would be cardiac until proven otherwise. Basically, these three forks help you get most of the way there to narrowing down your differential. Now that we've asked some focused history questions, let's revisit our 22-year-old and their case presentation. Our 22-year-old presents after a brief loss of consciousness while standing in line at a coffee shop. They report feeling lightheaded, nauseous, and sweaty just before the event. They deny chest pain or palpitations. They report the episode lasted less than a minute, and they return to baseline quickly without any confusion. They have no significant past medical history, and they take no medications. Remember earlier when I said there would be a framework to help you approach syncope? Here it is. You first want to check for red flags. If there are any, then you're going to refer to the ED for cardiac workup. But if not, we want to check, was there true loss of consciousness, because that's a key decision fork for us. If there was not, then it's not syncope, and you'd want to explore other options like seizures, psychogenic, or a fall. If there was prodrome present and they had true loss of consciousness, you could check to see if there was a vasovagal reflex, and there might be triggers like standing, stress, or pain associated with that. If they were standing and they had a orthostatic presentation, there might be volume depletion, medications could be causing this, or autonomic nervous system issues. Third, if there was exertion or they were lying supine when the episode happened, you'd be thinking of cardiac causes like an arrhythmia or structural problems. So again, your key diagnostic branch or fork is to determine whether it was true syncope or not. Now that we have so much more information, let's revisit our DDX list. Based on what we learned, I'm going to go with vasovagal syncope as my working diagnosis, but I'm still going to keep arrhythmia and orthostatic hypotension on my differentials list. So by using this framework and focus history questions, our physical exams are going to be much more targeted and focused. So make sure you don't forget to do vitals and check for general appearance, like they're working their accessory muscles for breathing, tripoding. In this case, it would also be good to check orthostatic vitals and probably a cardiac exam. But let's walk through this table here. For a vasovagal cause, that would be indicated if they were standing and had a prodrome. So we'd want to check vitals, look for general observations, and then probably do a heart and lung exam. For our patient, let's assume that all of those were within normal limits. If we suspected an orthostatic cause, they might be standing or dehydrated. So we'd want to check for orthostatic vitals. We'd want to do a heart and lung exam. And you could also check for skin turgor or mucous membranes if you suspected dehydration. And as a little reminder here, for orthostatic vitals, you'd want to measure blood pressure after lying supine for 2 minutes, then have them stand for 2 minutes, and then repeat your blood pressure measurement. If there was a cardiac cause, there's probably no prodrome, and there'd be some exertion associated with their case. So again, a heart and lung exam, and you'd probably want to order an ECG. So for our patient, let's say that those might be abnormal. And then if there was a seizure, post-event confusion would probably be present. So again, you'd want to do a heart and lung exam, but I'd also want to do a thorough neuro exam. For our case, let's assume that that was within normal limits as well. Now that we've performed all of our pertinent PEs, let's provide an assessment for our patient. So we have a 22-year-old non-binary AFib patient that presents with a brief loss of consciousness while standing, preceded by lightheadedness, nausea, and diaphoresis. They rapidly returned to baseline without confusion and denied chest pain or palpitations. In-office vital signs were normal, and physical exam was unremarkable. The presence of a prodrome, clear trigger, which is prolonged standing, and rapid recovery are most consistent with vasovagal syncope. Cardiac causes are less likely given the absence of exertional symptoms, lack of a cardiac history, and we had a reassuring exam today. Before we wrap up, I want to share 3 common mistakes students make with a Syncope Chief complaint so you don't fall for those traps. Number 1 is skipping severity assessment. Don't jump to the diagnosis before you ask about exertion, if there was prodrome, or any cardiac history, because if you skip that, you might miss cardiac syncope. Number 2 is not confirming true syncope. Again, jumping to the diagnosis without asking if they actually lost consciousness. Remember, that's our real discriminator here. And third is missing key pattern clues. So listing the DX before asking about prodrome, position, or triggers. Remember, pattern is our strongest discriminator. Here's the key takeaway. Always start with safety. Then identify the pattern, then use key diagnostic forks. Syncope is not about memorizing diagnoses. It's about recognizing risk stratification and patterns. If this helped you, check out the rest of the Chief Complaint Series, where we break down how to think through common presentations step by step. And if you're practicing for OSCEs, I've linked a couple of my favorite resources below. See you in the next one.